This module will discuss treatment notes. All of the documentation requirements and guidelines are found in the Medicare Benefit Policy Manual. Manual 102 includes more than 20 chapters, and Chapter 15 is the one that describes what is required in outpatient PT, OT, and ST documentation. The chapter, however, is named Covered Medical and Other Health Services. So when you go to find it, look for that one, and then go to Section 220 and 230, where you will find the therapy guidelines. National Government Services is the local Medicare administrative contractor for the state of Illinois. Therefore, you can find more guidance on its website. They have published a local coverage determination for outpatient PT and OT services, which all Part B providers of therapy in Illinois should be aware of. So throughout this module, there is additional guidance included from it. I did not include the web link for NGS because it is too long, but just Google search NGS for Illinois and you will be able to find it. So how does Medicare define reasonable and necessary? Well, Medicare thinks of services as reasonable and necessary if they are for the diagnosis or treatment of illness or injury, or to improve the functioning of a malformed body member. They go on to say that services must be of such a level of complexity and sophistication, meaning that if the services do not require the performance or supervision of a therapist, then they are not considered reasonable and necessary, even if they are performed or supervised by a therapist. Now, a service that would ordinarily be performed by non-skilled personnel could be considered a skilled therapy service in cases where the condition of the patient is such that the services can only be safely and effectively performed by a qualified therapist or under supervision. That means that there must be clear documentation that because of these special medical complications or special medical condition, the skilled therapist is required to perform or supervise the service. They do emphasize that the importance of a particular service to a beneficiary or the frequency with which it must be performed does not by itself make a non-skilled service into a skilled service. Have you ever stopped to think how you define skilled, reasonable, and necessary? If someone were to ask you to describe them, could you say it out loud? Most therapists have trouble defining what they are, but they hear them all the time. Webster's defines skill as proficiency, facility, or dexterity that is acquired or developed through training or experience. Reasonable is defined by Webster's as governed by or being in accordance with reason or sound thinking, not excessive or extreme. And Webster's defines the word necessary as absolutely essential, needed to achieve a certain result or effect. So do these make sense to you? Does that resonate with you? In my mind, when I think about these three words, I break it down to a skill is something that is exclusive to me, the therapist. So I need to make sure that I'm documenting something that indicates that only I can do it, whether it's a technique, whether it's an exercise, whether it's an intervention, whether I am describing the teaching or the training or the assessment that I'm doing. Reasonable is that the amount makes sense. So each day and over the course of an episode of care, the amount that I'm delivering makes sense given this patient's condition. And it's necessary. The care is indispensable. So I'm attempting to show through my documentation that this care is essential for the patient's functional returning to the patient's goals. So that's why I'm throughout the episode trying to refer back to those goals or functional improvements, specific ones, not just general ones, but specific and using objective terms. These are things that are important, and if you make sure that you can define them, then you are more likely to convey that in your own documentation. In documentation, it's also not enough just to show an increase in sets and reps. It's not enough to use phrases that your EMR has defined for you. It's not enough to use the terms included in the CPT definitions, especially when you are using them over and over. without individualizing them to the patient. It's by individualizing them to the patient that you demonstrate your own skill and the necessity of delivering those interventions to this patient. Here are some examples from Rock Valley. So this is a patient, and this is visit 2 on August 31st, 2018. You can see all of these exercises are done to increase right lower extremity range of motion or improve ankle mobility. The same patient 2 weeks later, visit 6. One new exercise, but the rationale for everything else is the same, and we're still doing the same list of exercises. Then on the same patient 3 weeks later, the only change that has occurred is we've dropped some, but we're still doing these same exercises that were done on visit 2, and we've only increased TheraBand. So if range of motion has been improving, then great. He should be able to do some of these exercises on his or her own. If it's not, then maybe we should try something new or explain why the patient still needs to do them with you. Ankle range of motion is not a very difficult kind of exercise or intervention. And so needing to be able to explain why active range of motion still requires the skills of a therapist on the 10th visit is very important. Now, this is a new patient. Visit 1, we have some stretches and we have some strengthening. 2 visits later, we have several new exercises added, and 1 was stopped, and we were given the explanation why, which makes sense. So several new exercises on visit 3. 3 visits later, and the exercises are progressed. So we see how even though we're doing some of the same exercises, those have been progressed in intensity. We're also added some new ones. We also see that some of the ones done on the first visit were not repeated. 4 visits later on visit 10, and we still have progression. So this shows that throughout the 10 visits, we have a lot more change going on. Sure, we could add more information, and hopefully in the assessments on these, there was additional information about the decision or what some of these exercises were done for. But the fact is that we're not repeating the same exercises each visit, and there is gradual progression of both the exercise protocol as well as the exercise intensity. Now, this is another new patient. We have some manual traction. This one has to do with manual techniques and soft tissue mobilization to assist in pain reduction and improved upper back range of motion. So visit 1, visit 4, we still have the same manual techniques done. We still have the same other information. Visit 8, no changes. Visit 12 and discharge visit, no changes. So if we go back to visit 1, 4/24 through 5/24, 12 visits, 1 month of service, the same manual techniques every visit. Again, this doesn't look like it requires the skills of a therapist to do the same thing over and over. Manual therapy is one of those techniques and one of those interventions, especially manual traction. If the patient is requiring manual traction on the last visit, then how is the patient going to be able to do that manual traction as a part of their discharge, as a part of their home exercise program? Has the patient been assessed as far as how they respond without that during a treatment? Those are things to think about that require the skills of a therapist and documentation to explain why we're still doing manual traction on the last visit. And another patient. This one is another example of manual therapy. So on visit 1, we have soft tissue mobilization and incisional mobilization on the right shoulder. On visit 3, there's a change. We're still doing soft tissue mobs to the right shoulder, but we're no longer doing incisional mobilization. The patient has been taught to do this on their own. On the next slide, there is no manual therapy done. So between visit 4 and discharge, there is no manual therapy done. Why? Because it's been replaced with functional activities. This would be expected as the patient shows improvement and as the manual therapy has done its job to increase range of motion, decrease pain, and enable the patient to do more functional interventions. This is another patient, and this represents educational interventions. So we have visit 1 and 3. Visit 1, education, anatomy, and pathology, but on visit 3, the education is slightly different. Notice on visit 5 and 7, we still have some different education that was done from visit 1 and 3. On visit 9 and 11, we're still changing the instruction and the cueing, so we're not just having the same description every visit. Again, visit 5, visit 7, visit 9, we've added some about the elbow at 90 degrees with all external rotation based exercises. So we still have some modification and some changes going on. That's very important so that the visits don't look repetitive, so it doesn't look like we're doing the same custodial education every visit and billing for it. And that concludes our module on treatment notes.